Go. All right, so I'm going to go ahead and introduce you. Everyone, thank you so much for your patience. We were having a little bit of technical difficulty there, but I think we are all set and ready to go. I appreciate it. Hope you had a good break. I am going to introduce two of my colleagues from Mary Washington Healthcare. We have Rachel. Now, for some reason, I always want to say Frakes. Forgive me.
Frakes, yes, ma'am.
Frakes, okay, Rachel Frakes, who is a speech language pathologist. And we also have Lauren Anderson, who's on here, and she is we just say COTA typically.
Yeah, COTA, yep.
Okay, all right, that's just a lot of things to say here. So I'll let you all introduce yourselves, and we will monitor the chat for you. So if there's any questions, we typically will wait to the end, but if there's something that's pressing that one of the participants might want to ask, we'll take care of that and we'll read the questions for you. So don't worry about monitoring the chat. We'll take care of that. Okay, so you all can go ahead and get started.
Sounds good, thank you.
You're welcome.
Yeah, welcome everybody. So my name is Rachel Frakes. I'm a speech and language pathologist, and this is Lauren Anderson. She's a certified occupational therapy assistant. We are going to talk today about a particularly challenging and rewarding patient that we've been working with here in the hospital for over a year, actually. But first, we wanted to provide a little bit of information about speech language pathology and occupational therapy in case anybody is interested in pursuing careers in either one of those realms. And tell you a little bit about ourselves as well. All right, so first off, who am I? I am Rachel Frakes. I am from the Fredericksburg area. I have been here almost my entire life. So I got my undergraduate degree from Mary Washington College when it was a college, not when it was the university that it is now. My degree is in biochemistry. And then I went to the University of Virginia. After spending a year teaching, I decided to go back to school and got my graduate degree in communication disorders from UVA. I have been a speech language pathologist for 15 years. Most of that has been here at Mary Washington Hospital. That's my favorite place to work as an acute care. But I have also worked in psychiatric facilities, nursing homes, outpatient clinic, and the schools. And like I said, I live here locally. I actually live out in Caroline County, where we have a horse and cattle farm. So next up is Lauren.
Yeah, my name is Lauren Anderson. I'm an OT assistant, and the acronym there, it just stands for Certified Occupational Therapy Assistant, and the L just means I'm licensed. So the different disciplines have different acronyms for the different levels of certifications that they get. So I have my associate's degree from Jefferson College of Health Sciences, that's in Roanoke. I originally, when I started thinking about what I wanted to do for school, I really wanted to get into psychology and wanted to do some sort of like family and marriage therapy. And then I wasn't quite sure if I wanted to continue to pursue that. And I found out about occupational therapy. And I was able to work with a little boy, he was 2 years old, and I was able to help. He had a physical disability and he wasn't able to eat or talk. So I was able to work with speech, PT, and OT with him and see the interventions they did with him. I worked with him for a year, and that's kind of what got me into wanting to do occupational therapy. And I've been here at the hospital for almost 6 years, same as Rachel. I love acute care. I did a short stay at an assisted living facility before I came here, but this is definitely a good fit for me. I really enjoy the acuity of this setting, and it's very, very rewarding. I feel like regardless of what we do every day, we're always helping people. So I feel like this is a really good setting to be in. And yeah, I have lots of house plants and I'm very into doing stuff outdoors and gardening. So a lot of the times I try to, when I'm working with my patients, try to incorporate what they like to do in their day-to-day life and try to incorporate the personal things they enjoy into our therapy sessions.
And the focus of our presentation today is going to be on speech pathology and occupational therapy in the hospital. But at the end, if anybody has questions about any of the other settings, feel free to ask because we've been around the block a few times, so we should be able to answer the questions for you. All right, speech language pathologist, what do we do? Most people have not ever heard of a speech language pathologist at all. But if you have, generally you think of them as the speech teacher in elementary school that teaches children how to not lisp or how to say their R's correctly, because those are particularly difficult sounds. And we certainly do that. Actually, a vast majority of speech pathologists are employed in the school system, but we do show up in many other places as well. So we, as speech pathologists, it's good to enjoy working with people. We work from newborns all the way till the elderly, and we collaborate with a lot of different healthcare professionals in the hospital. A love of science is very helpful because you're going to have to learn a lot of it for human anatomy and neurology and linguistics in order to learn everything you need to know. And then one of the great things about speech pathology is that it's very flexible. If you are like me and you get bored very easily, you can work in a hospital, you can work in a school, you can work in a nursing home, you can work for home health. There are many different options. So if you get into something and find out that it's not your cup of tea, with that same degree, you have many different places that you can go and many different things that you could try until you find what really does suit you the best. Here in the hospital setting, I like to call us a cross between a physician assistant and a counselor because you are assisting the doctors in your area of expertise, which in our case is communication and aerodigestive disorders. But you're also spending a lot of time counseling patients and families about all sorts of things related to communication and swallowing. All right, some information about speech pathology. When I first made this presentation just a few weeks ago, they had the 2021 data out that ranked us 7th top career in the nation. US News and World Report did the study. And then number 4 for the best healthcare job. And then I actually looked up the most recent data. They've got 2022 coming out now, and we've actually moved up to number 3 as far as best healthcare jobs go. We are behind nurse practitioners and physician assistants. So overall, a popular place to be. And some of the information from the slide gives you the salary range, which is always important, and also varies a lot depending on how much education you have in the field and how much experience you have in the field and where you work. People that work in the school system are going to make a different salary than people that work in the healthcare field. But the ballpark figure that US News and World Report put out there is $66,000 in the school setting to $78,000 in more of a healthcare related setting. The education that you need is a master's degree. Your undergraduate degree can be in pretty much anything, but you do have to receive a master's in communication disorders, and then you have to pass a board exam to be licensed as a speech language pathologist. So the master's program is about 2 years. It includes a lot of coursework, and it also includes a lot of practicum work. So you're spending time in clinics learning how to treat patients, not just spending time with your books. And then you also have to complete a 9-month fellowship where you're seeing patients and you're a licensed speech language pathologist. You're just getting extra support to make sure that if you have any questions, there's someone there to provide you with answers. And then after that, you are fully licensed and ready to do whatever you want within the field. So this slide tells you some different places that you can find speech pathologists. When I went back to graduate school, my roommate from undergrad actually decided to go back to graduate school at the same time. We had no idea that we were both going back to school for speech language pathology because we had lost touch. But the two of us demonstrate a lot of the variability in the field. I majored in biochemistry. She majored in linguistics. Once we got into graduate school, I loved all the science and anatomy and neurology, and she loved all the phonetics and the speech science and language. I liked adults, she liked kids, and now I work in a hospital and she works in early intervention in people's homes with children under the age of 3. So it just kind of demonstrates that we are all over the place. There are a lot of different options for places to work and disorders to treat. As you can see on the slide, some of the stuff that we do work with are speech disorders, which is making sounds as you talk, language disorders, which is thinking of the words that you want to use as you say them, gender affirming voice services. So if you prefer to your voice to sound a different way, we can work on pitch, we can work on articulation, in that manner. And then swallowing disorders is kind of a whole separate ball game. That's for people that have trouble eating and drinking. We're going to talk about that later on in the presentation. And then cognitive linguistics is anything that has to do with thinking. So knowing how to problem solve, knowing how to reason, knowing how to make a good choice. Those are all things that we work on. And we already talked about all the different settings that you can see us in.
So for occupational therapy, I've always kind of liked to consider OT as a very well-rounded therapy. I feel like, especially in this setting, a lot of PT and OT cross over each other a little bit, and a lot of OT and speech cross over each other a little bit. I feel like we all can touch on different areas and different aspects of everybody's life. But for OT, we try to do like a whole person approach. So we try to look at somebody from every aspect of their life. And it could be anything from the beginning of the morning when they wake up to when they go to bed at night. Anything that could happen during their day, that's something that we could potentially work on. And we really want to focus on whatever is going to be most purposeful to the patient or the client that we're working with. You know, at the end of the day, especially in this setting, that person is still their own self. And it's hard here in the hospital because they have different therapies, different doctors, different nurses, everybody coming in and kind of controlling a lot of their life, and they lose a lot of their autonomy and their independence here in this setting. But I feel like therapy, and especially OT, we're able to really go in and ask them, what do you want to work on? What's a goal that you have for yourself? There's a lot of this that's out of your control right now, but what's something that you can control and what's something that you can try to focus on? We want to try to get people as independent as we can, given the circumstances. Whether that be they need equipment or they need caregiver support or they need to modify their environment. We kind of try to look at all different aspects of their life to see what we can use to try to help make them as independent as we can. And like I said, anything that might be important to them. So if somebody here in the hospital, if their biggest thing is they want to be able to feed themselves, that might be our biggest focus, is bringing their hand to their mouth, working on exercises to be able to do that range of motion. If somebody's working in home health and they're working at their home, it might be anywhere from like helping them to learn how to take care of their dog, if they're able to be strong enough and their balance is good enough to be able to scoop the food out of the bag and pour it in the bowl, and safely manipulate taking the dog outside to take it for a walk. So there's a very large range of stuff we can work on, and it just depends on what setting we're in and what the patient themselves want to work on. So it can be pretty diverse, and that's one thing I really do like about our field. So the biggest things, our biggest, like, I guess, bread and butter, you would say, we call them activities of daily living. So that's any activity that's oriented to kind of taking care of yourself. So like for the first one, they're bathing and showering. That could be anywhere from physically getting into the shower, being able to undress yourself, safely transfer into the shower, whether it be step over a bathtub or walk straight in. If you need to sit in a chair to shower, if you need a hose that can come down if you're not able to reach it, having the balance and the coordination to be able to safely shower, make sure they're not going to turn the water on too hot, make sure it's a safe temperature, make sure they're going to use, if they have any cognitive deficits, make sure they're going to use the shampoo for their hair and the soap for their body, and not vice versa. So there's every aspect we can break down, every activity, and that's something we would work on. And here in the hospital, if they're bedbound for whatever reason, their bathing and showering might just be, do you have enough strength to just try to wash up under your armpits, just to wash your face? So it can be very minimal, small movements we do, or we can do the whole big aspect of the whole full-on shower. And so that goes for dressing, all the grooming, self-care stuff. The eating and swallowing on there, that's a little bit more speech. We do focus a lot on the self-feeding, bringing hand to mouth, the fine motor coordination. If some people have like a vision deficit and they can't see half their plate, making sure they scan their whole plate to make sure they're able to see everything on there. And speech focuses a little bit more on the actual swallowing aspect. And then, you know, functional mobility, that's transfers, walking, any sort of mobility, using a wheelchair. And then, you know, putting on your glasses, putting in your contacts, anything that would be in your day-to-day life. And then we would also work on the instrumental activities of daily living. So that's more of the larger tasks that you could potentially have somebody else do for you. And even the activities of daily living, a lot of people might need a caregiver to help them with some of those things. And that would be a big part of our job too, is educating the patient and the caregiver or family member that's helping them to make sure they know the best way to support them and help them be as independent as they can. But for the instrumental activities, that would be, you know, taking care of your kids, taking care of their pets, driving, getting to and from the grocery store, grocery shopping, meal prep. So there's a lot of stuff we work on. And once again, it just depends on which setting we're in for what we're going to focus on. So the salaries range a good bit. So for between OT and COTA, there is a decent gap between the pay raises depending on what setting you work in. But also for an OT, you might have a little bit more student debt than an OT assistant. So in the next slide, I'll get into a little bit more about the education required. But these are the different settings that you can work in. So acute care, inpatient, sometimes you make a little bit less in those settings, and then in home health and the nursing homes, a SNF, SNF, that's called a skilled nursing facility. That would essentially be like a kind of nursing home facility, and people do typically make a little bit more money there, and in home health as well. And you can see there the graph on the other side, all the different settings that people do work in. A lot of hospitals, a lot of school system stuff, and there is a lot of mental health. Occupational therapy actually originated and was like founded, initially started with mental health back in like the 1900s. So that's where like our base is just trying to keep people as, try to make their life as worth living as possible. So we do try to work a lot of even if we're working with patients in the hospital, there's still a lot of mental health aspects we work on, even if that's not our main focus for our treatment. So for the education for a COTA, it's an associate's degree, typically 1 to 2 years of schooling. There are the 1-year accelerated programs, but I have found, I've had a couple students that have been in the 1-year accelerated program. It is pretty intense. You are pushing through that program pretty quickly, and they've always been fine. You know, when they come to me as a student, they're fine, but it is a lot in a short period of time. So my program was 2 years, and then there's typically like a 16-week field work where it's 2 8-week-long field works. And you can typically choose what kind of setting you want to be in. And when I was able to do it, I was able to do mental health and then like an inpatient setting. So you can kind of figure out if you want to try to work more towards peds, more towards geriatrics with the older population, inpatient acute care like we're doing. There's lots of different options depending on where you want to go for your field work. And then that can kind of help you determine where you might want to work once you do graduate. And any type of hands-on experience you can get before applying to school, I think is really beneficial, especially hands-on with like actually being hands-on with somebody. I think that's one of the toughest things I see when people are starting. They have a tough time getting hands-on with the patient, and that makes them a little nervous. So if you're able to if you're able to do any sort of volunteer work in any sort of hospital, nursing home, any sort of facility where you can be a little bit hands-on with people, I find that that can really help people when they start in school. And then when they're in their field work, it can kind of put them a little bit ahead of people that don't have the hands-on experience.
All right, so we're going to move on to talking about patient X. So this is a patient that we have been working with, both of us actually, for over a year now. When he first came to us, he had already been in the hospital for 5 months. He had a massive heart attack and then a stroke, which deprived his brain of oxygen for an extended period of time. So when we first met him, the term that was being used to describe him was that he was brain dead. You can see on that slide there a description of what we call locked in syndrome. So that basically means a person is awake in a sort of coma. They cannot talk, they cannot produce any movement, they can't eat or drink. What they usually can do is move their eyes around and blink. And we're pretty sure that they can hear and also think and reason. So they would be able to say, listen to someone, read them a book, or listen to people have a conversation in the room. But for all intents and purposes, to anybody that's looking at that patient, they pretty much look like they're just laying in a bed, not able to move, not able to talk, not able to do anything, just a person in a bed. So when we first got the consult to go see this patient, we went in not really expecting a whole lot, because like I said, they had been using the word brain dead to describe him. One of the things that speech pathologists are trained to do is administer what we call objective tests. So they wanted to know, can this patient actually understand anything, do anything, or is there really nothing going on in his brain? So we have a testing protocol that's very specific for picking up on those things. So we went in and gave that test to him. It's called the JFK Coma Recovery Scale. And he didn't do so hot. He only got a few things right out of the whole test. And honestly, it wasn't really even enough to say that for sure that he could understand anything. But every once in a while, you'd see kind of like a flicker in his eye or a movement where you thought maybe he was trying to communicate, maybe he was trying to respond to something that you were doing, but it certainly wasn't big enough or consistent enough to say yes, for sure. And that's one of the reasons that we do these tests, and we've gone through all the training to do these tests, is because the test will tell you objectively for sure, can this patient understand you? And it takes out the realm of you just wanting him to understand you. So I might be seeing him answer questions because I want him to answer questions. But these tests help us make sure that that's not what we're doing. We're relying on something that's actually objective and reliable to tell us if he is answering questions or having anything going on in his brain. And one of the very challenging things about this patient as well was he had no family, no friends, no visitors in the hospital. It was during the COVID pandemic too, so we didn't have visitors in the hospital pretty much, period. So we had nothing to go on about what he was like before, what kind of music he might like, what kind of hobbies he had, what kind of job he had. We had absolutely nothing. We just had a patient in the bed that could not do anything. So the first thing that we started with is what we call coma stim. So we would go into the room and basically spend time trying to stimulate him out of his coma. And a coma, as the slide tells you there, is a profound state of unconsciousness. So you're not following commands, you're not talking, you're not trying to talk, and you're not trying to move. You're pretty much laying in the bed. So coma stim is pretty fun, actually, because you get to go in the room and try to stimulate everybody's senses. So you get to hop around and yell and scream to try to stimulate your hearing sense, clapping your hands and acting like a fool to try to get any sort of response. You also can try to play music. I don't know if anybody watches Stranger Things, but I do. And they played music in there to try to reach a different place in the patient, well, it wasn't a patient there, a different place in the person's brain to pull them out of the upside down. And so, and it worked in Stranger Things. And I think it does stimulate a different place in your brain. That part is true. And the other example I have from that, from a personal experience, I was in a coma from a car accident and people were in the room talking to me, I've been told, over and over and over, and I don't remember anything that anybody said, but I can remember my husband singing. So weird, and he shouldn't have been doing that because he did not sound good, but so music is a different part of your brain. So that would be, it would have been better if we knew what kind of music he liked. We know now, but a little late. So it took us literally weeks of going in there, clapping, playing music, acting like a fool, putting things up to his mouth so that he could try to taste, using your sense of touch, like fingers in water, to try to stimulate any sort of response. But we did eventually get a response. So after we could say that he was no longer in a coma, we could say, yes, we know this patient is not brain dead. He's done enough on these tests to be able to show us that he is understanding at least some of what we're saying, that he is interacting with his environment and with us. So we know there's something going on in there. So what we need to do now is help him communicate with the rest of the world, because he's essentially laying in the bed now, knowing what's going on, but totally unable to interact at all with his environment, because we're still not really moving. We're not answering yes and no. We're not talking. We're not eating. None of that stuff. So that's when the real work started getting going. So we worked on yes and no first, because that is one of the things that speech pathology will go after to give people a meaningful way to communicate, because yes and no is simple, but also pretty profound. So it took, as you see on the slide, like 100 days, but we had 100 days because he was hanging out with us in the hospital. And what we would do is model like yes and no answers. So we'd physically take his hand, put his thumb up, and ask a question for something like his name, or do you like music? Something that should have a simple yes and no answer. And then we would model the answer for him to help him learn the correct response, and then to help reactivate those pathways in his brain so that when we ask something that we don't already know the answer to, he's able to pull that out and answer for us. The first time we actually, or that I actually saw him answer, we had done a lot of that modeling, thumbs up, thumbs down over, really simple questions, but nothing where I could say for absolute certain that he was grasping what we were doing. But I went in the room one day and was just rambling, talking while I was getting the room set up for his therapy session. And I happened to walk over to the window and the sun was shining through the window, like right on his face. And I was like, man, this does not look comfortable. Do you want the blinds closed? And he picked his hand up and did his thumbs up. And I was like, oh my. So we closed the blinds. And that was the first time that I was really like, wow, he really does get it. We are making progress. He is in there. So then we could move on to doing yes and no about other things. We knew he liked to watch TV, or we thought he liked to watch TV. We could see that he was looking at the television, I guess. But lots of times you'd go in the room and the nurses would have like cartoons on, or things that you wouldn't really think he would be interested in watching. So we spent a lot of time with the TV remote going through, do you want to watch this channel? Yes or no, thumbs up or thumbs down. And it took a lot of patience. and a lot of determination, but we were able to figure out eventually that he really liked to watch sports, especially football, through that using yes and the no. And then one of the things I wrote on the slide, that there is no meaningful yes unless the individual could also have said no. So one of the things that we did in the beginning a lot, you have to find something that's relevant to the patient. Like, he has to want to communicate with me, or he's just not going to. You know, he's had months and months now of laying in a room, not interacting with anybody. So we have to find something that means something to him to make him want to communicate with us. So one of the things that I would do a lot is ask him, do you want to participate in therapy today? And if he would tell me no, then, you know, for that to have any meaning, I had to be like, okay, well, then I'll leave and I'll see you later. So a lot of our therapy sessions were, do you want to have therapy? And if he said no, then walked away. But eventually we got farther than that. And the TV helped with that when we were able to figure out what he did and didn't like to watch. So that is where we went with that. All right, so he started out with no way to communicate. He could not talk and still cannot talk, which we'll kind of get into why he could not talk a little bit later. But talking was not really a viable option. So after we got through the yeses and nos, then we needed to, you know, kind of come up with more profound things to say. And we decided to focus on writing since the talking wasn't really going to work. Occupational therapy helped a lot with how are we going to write, the physical mechanics of holding the pencil and positioning so that he could actually have the opportunity to write. And then speech pathology worked more on what are we writing, like actually pulling the language out of your brain to make a message. So it was definitely a big joint effort to get him writing. And still, when I go in the room and he's all squirreled around in the bed, I don't know how to position him correctly to get him to use the pencil. I need my OT friend to help get his arm in the right spot so that he can write. But he actually, after a few sessions of writing a lot of who knows what scratches, he got out a real sentence. He went in there and handed him the clipboard one day and was like, just tell me something, anything you'd like to tell me. And I honestly did not expect him to say anything. Like, I thought I was going to get the scratches that I usually get. And he wrote out very clearly, I love you. And he did it to the occupational therapist and the physical therapist that's been working with him too. So whole sentence. But again, the communication had to be something meaningful to him. He probably wasn't that motivated to tell me, I want a soda or something like that. It had to be something that meant something to him. But it did help us know that, yes, you can write, you can make a whole sentence. So that is now something that we can work on, making you or helping you make sentences about other things to help you have a little control over what's going on in your life every day. So that's where our focus is right now with the communication. We are working on writing.
So for OT, can I go right here?
Yep.
Yeah, so for OT, once again, OT, PT, speech, we've all been crossing over each other a good bit, I feel like, throughout his stay here. Initially, he was only following about 5% of commands. At the initial evaluation, he would track with his eyes, which means like if you walked around the room, he would follow you with his eyes, but it's not like he was necessarily really intentional with it. It was almost a little more reflexive. And so we initially focused a lot on just trying to have him do simple command following. When we would say his name, try to get him to look at us, try to pay attention. Focus a lot on the arm exercises, trying to get his range of motion moving, and a lot of stuff Rachel said with communication. We're at the point now where he can write, but he still does also communicate a lot with giving a thumbs up and a thumbs down, and also shaking his head yes and no. And he's very, very stiff and tight all over. When we first started working with him, we didn't have much range of motion in his arms or legs, which means he's just really, really tight. And so we initially were working a lot on his range of motion in his thumb. So doing exercises on the thumb and the hand to try to get it as open as we can so he could give us a thumbs down or a thumbs up. Same thing with his neck. His neck has been really, really stiff and he's kind of just really tight up here. So a lot of it is trying to get his shoulders to relax and try to gently stretch his neck so he can work on shaking his head, you know, up and down, yes and no. And now we are able to work on him holding the pencil. We have a clipboard that he uses. We've tried like communication boards. So just like a piece of paper with pictures of like a TV, a drink, a toilet, to be like, hey, point to us, you know, if there's something you need. We haven't had the best luck with that quite as much. He still prefers thumbs up, thumbs down, shaking yes and no. And then we also focus a lot on positioning in the bed to prevent bed sores. So that's a huge part of our therapy sessions with him, is just getting him in a good position to prevent him from getting any contractures, which means having his muscles kind of tighten up and get stiff, and also trying to prevent bed sores. So keeping his arms in a neutral, good position, keeping his feet in a good position, having him shift side to side in bed to get weight off of his bottom so he won't get a pressure wound back there. And a lot of the times we do OT and PT together. It's called a co-treatment. So we might have, you know, him sitting on the edge of the bed or sitting in the recliner chair, and PT is focusing a lot on his trunk control, his core muscle strength, his balance to, you know, work on. We having him lean forward and back, side to side to get his trunk strong. So eventually, which we're able to do now, he's able to sit up on the edge of the bed, hold himself up while he's eating. So PT might be focusing on, you know, having both of his feet on the floor, getting his knees and his ankles to be able to bend and get some weight through them, working on his balance, while OT's up front, working on feeding or washing his face or any sort of self-care task. So a lot of the stuff we do, we kind of go in together. And so now he's at the point where he's almost, if he's in the right mood, he'll almost follow like 100% of commands. I actually worked with him this morning right before I came here, and they had just got him out of the bed. It's called a Hoyer sling. It's like a mechanical lift that lifts him up and can transfer him from the bed to the chair. And they were actually transferring him to the chair when I got in there. And he was really flat this morning, which just means he was kind of quiet and not wanting to talk very much. And it's just because he was so sleepy. And a lot of the times I found, and with someone like him with a brain injury, sometimes at the beginning of the session, they aren't very responsive and they're pretty quiet and withdrawn. And towards the end of our hour-long session, in maybe like the last 10 minutes, it's almost like he wakes up and his brain kind of becomes more alert and he starts to communicate and starts to like hold intense eye contact. And it's just been a pretty wild ride to watch him change as much as he has in the past year. So yeah, if he wants to do it, he'll do it. Sometimes he's not really feeling it. And there's been times before he's actually told us to like get out of his room. Whereas one day we were like, Sean, do you want us to leave? And he nodded yes. And he was kind of like waving us out of the room. We're like, okay, we know we're being annoying. So it's good when we notice he's starting to like kind of show his own personality as he's come along. It's been pretty cool to see him progress. So yeah, the biggest things we're working on now is we're trying to work on the communication still. We're trying to work on the writing. We've been working on him pressing the call bell for the nurses, changing the channel on TV, still working on a lot of self-feeding stuff. And he really enjoys eating. And that's one thing that it's like a pleasure response. So he's doing an activity, but he's also enjoying being able to eat. So it's not like we're just cranking him through arm exercises. It's like he's doing the exercises, he's working on his motor coordination, while he's also enjoying it because he's being able to eat something. So once again, we try to tie in our therapy with something that the patient might like to enjoy doing. We've taken him, we have a therapy gym. We've gotten him in a wheelchair, taken him up to our therapy gym, gotten him in front of a computer, tried to have him type on a keyboard. We've gotten him in front of a long mirror so he can kind of see himself and try to work on his balance, try to work on his arms while he's able to see himself. He's able to hold a mirror with one hand and brush his teeth with the other. And I know some of these things might seem like they're very, very small and they might not seem like a big deal, but for us, when we've seen him going from literally doing nothing to now he's at a point where he recognizes us when he walks in the room, and he does participate really well when he's in the mood to do it. So we've been able to do quite a bit with him, and it's been really interesting to watch him kind of progress. We all kind of feel like he's almost like our kid. Like he started out as like a baby, like he wasn't able to do much of anything. And every day he's able to move something new for the first time or communicate for the first time. And like Rachel said, the day he wrote "I love you" was huge for us. And yesterday I actually went to go work with him, and I asked him if he wanted me to work with him now, and he said no. And I said, "When do you want me to come back?" And he put his hand up for 5. And I said, "Well, I can't come back that late. Is there another time?" And he wrote 4:30 and underlined it and looked at me to be like, "I want you to come at 4:30. So all of those things are huge deals that he's gotten to the point where he's able to communicate to that extent.
So eating and drinking, that is another huge thing that speech pathology does, mostly in the hospital. You'll see some people work with it in like skilled nursing facilities, and it's also a very big area for premature infants. They often need a lot of help eating and drinking, but again, that's something that you see mostly in the hospital. So our patient was not able to eat or drink. He had a tube that ran right into his stomach, where all of his food and fluids and medications went. So nothing went through his mouth because his throat was not working correctly. So if you see on the slide over there on that part that says passing mirror valve, he has what's called a tracheostomy. So because of the medical problems that he had, he needed help breathing. So the tracheostomy is putting essentially a hole in your neck into your airway so that you can breathe. You can see in the picture there the tube that goes through the front of your neck into his airway to help him breathe, which is great. We all need to breathe. But unfortunately, it then messes up your ability to talk and to eat and drink. So that was one of the reasons we were having so much trouble with getting him to talk and why he still doesn't really talk. But there is something that speech pathology can do with that tracheostomy. It didn't work in his particular case, but it does work for a lot of people. It's a valve that we have the training to fit people with and use that restores their ability to smell and taste and talk. So the talking didn't work out so well for patient X, but it often works out for other people. And it's one of the really rewarding parts of our profession in the hospital is taking somebody that's been in the hospital for probably weeks, not able to talk at all, and working with them on wearing this valve so that they can then speak. And that hearing what people have to say for the first time is always pretty exciting. So didn't work for this particular patient, but it is something we work with an awful lot, and it does have a good high success rate and is really fun. And in his case, it did help him with the eating and the drinking. So the valve restores your ability to smell and to taste. So it put some of the enjoyment back into eating and drinking, and it kind of helped him want to eat and drink. And then we had to make sure that his throat was actually working correctly, because you can see in the picture, you've got plastic and a lot of plastic in your throat, which makes it difficult to swallow. That link in the slide, I am not going to try to pull it up because we had trouble getting our slideshow up at all, but it should work for you if you would like to look at it. It is a comparison of an X-ray comparison of a normal swallow and an abnormal swallow. So one of the things speech pathologists do is take patients down to radiology and take X-rays of their throat to see if the food and the drinks are getting down the right way. And if they're not, what we can do to help that be better. So in this patient's case, once we put the valve on, he actually did pretty good with the swallowing. We didn't have a lot of trouble with things getting down the wrong pipe. But what we did start with, because he had a lot of sensory impairments from the brain injury, so that just means that he might not necessarily know that there's food in his mouth because he can't really feel it. That pathway from the sensation to his brain was interrupted with the brain injury. So you can end up looking like a chipmunk. You pack all your food into both your cheeks, and you're just hanging out happy as can be because you don't have any idea that it's there. So we had to do a lot of work with finding foods that are soft consistencies that aren't going to do that, and then educating people on how to help him so that he can swallow that food and not get choked on it. You'll also see speech pathologists sometimes change the consistency of liquids. Drinks tend to be real hard to swallow because they're slidey and hard to keep together in a bolus, and they move quick, and it's just really easy to choke on them. So what we do sometimes is make them thicker, kind of like tomato soup consistency, and that makes it easier to swallow them. So that is something that we have worked on with this patient as well. And it seems like it has definitely helped a lot with his quality of life. He really seems to enjoy eating and drinking. And thankfully, we were able to get him. He went from the point where he was using the tube on the left hand of that slide for everything. All his food, all his drinks, all his medications went through the tube. And we are at the point now where he is getting meal trays of a fairly normal diet. And if he has the right person in the room with him who can spend the time making sure he's following all the right strategies, he can pretty much eat anything he wants. So that was a big win for him to go from having a tube where you don't get to taste anything to eating whatever he feels like he wants to eat. A big win definitely seems to have made him a much happier person, which is what we're after. All right, so our last slide just has that phrase that medicine adds days to life, but therapy adds life to days. So when we met this patient, he was alive. Medicine had saved his life, but he was laying in a bed, not able to eat, not able to drink, not able to talk, not able to move, not able to do anything for himself. So it doesn't seem like that would be a wonderful existence. So therapy was able to work some life and enjoyment into that existence. And like we talked about, he can now feed himself, he can communicate, he can do things that he enjoys, like watching TV, getting in the wheelchair and going for a spin around the hospital or outside. He's made a lot of gains in a lot of areas. And part of our job is to educate everybody else in the hospital so that they know he can communicate and what he can do, because it's still easy to look at him and say, oh, I don't really think he does much. He looks like he just lays in the bed and we have to do everything for him. But educating everyone is part of what we do, so that they will give him a chance also to communicate and be in more control of his life from day to day.
I basically voiced everything what Rachel said. I feel like just in general, if you're thinking about getting into healthcare, it really is incredibly rewarding. And I've never had a patient like this that has been here for this extended amount of time. So, there are challenges to a lot of the stuff we've been doing, and we have to be pretty creative with a lot of the stuff we've had to do with him. But it's always been very, very rewarding, and it's pretty impactful how something like as little as some of the stuff that we do every day has made like a huge, huge difference on the quality of his life. So, like I just tell anybody that's looking into the healthcare field, like you really will go into work every day and you truly will like change somebody's life. Like I've done retail, I've worked in restaurants, all that stuff. And it's definitely like a whole different world in healthcare, but it's pretty incredible what you can do. Like you're going somewhere and you're spending your 8 hours at a job, but you're also able to, you leave every day and you like genuinely did impact someone's life, hopefully in a positive way. So yeah, OT, speech, PT, all of the therapies. It's a really good, it's a good field to be in. It's a good field, I feel like, to spend your time in, if that's something that you're interested in. Do you want to show any of this stuff? Or do you think we should?
Show off anything you want to show off.
I'll just show you guys real quick.
Oh, okay.
We had a couple visuals to show you, but I realize we've got like 5 minutes left. We actually used all of our time.
We did.
Yeah, great use of time.
Just want to show you guys real quick. This is one of like the items we've used to help him write. It's just like built up foam we put on a pencil. And this is like, I don't know if you're able to see anything that he's been writing, but that's the 430 right there that he wrote for me. So it's pretty scribbled. But these are some of like the tools we'll use to try to help him with his communication.
Yeah. And some of the really, I think, fun part and amazing part about therapy, especially speech and occupational therapy, is a lot of what we do with people is not really dependent on a lot of fancy tools and toys. It's dependent on what you know in your brain, what you've learned in school, and what you've learned from in the field. You pretty much, your brain is your biggest tool. So that's pretty cool to know that you can impact so much just with what you know. The last slide there has our national agencies. So if you are interested in wanting to pursue either occupational therapy or speech language pathology, those two institutes have a wealth of information and will tell you exactly how to get started. Did anybody have any questions?
Yeah. Okay, we're looking in the chat. How about it, participants? Any questions for our professionals? Anything that you can think of that you'd like to ask?
Hi. Yes, I just have a couple questions. I had a little bit more, but I know we're short on time. So I'll just ask two of them. I was just wondering, I'm sorry, I have so many questions.
Okay.
So I know that when you have like special needs kids use like the AAC devices, do you all use those when it comes to like speech therapy, or do y'all use that as like a last resort if you're not really getting the I guess answers that you need or like the results that you need? Do you even use the little talk touch devices?
Yeah, so the AAC devices are awesome. They've definitely come a long way in the last few years too. They're much easier to use now than they used to be. We don't generally get people set up with them in the hospital. That's usually something that an outpatient clinic would work on. But as speech pathologists, yes, it's definitely something that you work with. The tricky part about those devices is there's the speech that is making your muscles move to talk. And they are great devices for people that can't make those muscles move to talk. But then there's also the group of people that are having trouble communicating because the language center in their brain isn't working correctly. So unfortunately, you have to have some knowledge of language to use those AAC devices. So sometimes they don't work out the best for people with language disorders, but they are, sometimes they'll incorporate pictures. So there are ways you can get around it. But yes, for people with motor speech problems, you see them used in adults as well all the time. Yep.
Okay.
Listed.
And last question. Okay, so hopefully this is not off topic. But have you ever had to like reassess or revise another OT or speech therapist like assessment due to disagreeing with the plan that they came up with or the outcome of the treatment?
Sure. So we work as a team, and as a team of professionals, part of our job actually every year is to make sure that everybody on our team is up to speed with the skills that they need to be able to do their job. So we do review each other every year as kind of a checks and balances system to make sure that everybody can do what they need to do. And then as far as particular patients, there are always gray areas. I think just you have to be aware that my way is not always the best way. My way might be different than your way, but lots of times that other way is just as effective. It's just different. There are many different ways to end up at the same outcome. And sometimes it's just hard to recognize that you're going to reach the same outcome with a different method. Your method just might not be my method. But I think as professionals, as licensed professionals in healthcare, we all always want to learn. And I've never had anybody be upset about discussing a patient to say, maybe this would work better. Hey, have you tried this? Did you think about it this way? Because we're all problem solvers. That's why we're in therapy. We like to solve problems and we like to help patients. And we like to work together as a team. And here in this setting, especially, we're very blessed to have a great family of therapists. And we work well together. Another good question.
Yeah, thank you for asking those good questions, Kayla. We appreciate it then. So I'm looking at the time and I am going to go ahead and thank our presenters first and foremost. Then you two work well together, you know, in terms of presentation skills. I appreciate the stories. I appreciate learning about your example, your patient. And I think I'm positive that our participants have learned something different, a little new about occupational therapy and speech language therapy. So we appreciate your time so much. And participants, as usual, I am dropping the evaluation in the chat. And of course, you can, wait until a little bit later on. Please complete the evaluation for us. Give us some feedback on this presentation and some of the others that you have attended today. And then our next agenda item is actually lunch. All right, so we'll have lunch from 12 until 12:30. And then right after lunch at 12:30, we'll have a presentation on telemedicine. So please come back after lunch. We're looking forward to seeing you. Thank you again, presenters. We appreciate your knowledge and your expertise, and we'll see everyone after lunch. I'll talk to you all soon. Thank you.
Thank you.
Thank you, everybody. Appreciate it.